Thanks very much. And we're going to move away from the brain and talk about the only thing that we're going to talk about, the kidneys today, is urinary tract enlargement. When Gianluigi first asked me to talk about this, I thought it was abnormalities of the urinary tract. And then he said, no, we did that last year in the basic course. What I want you to talk about specifically is about enlargement of the urinary tract. So I had to rearrange all my slides, but they are all on your CD, so you don't need to take any photos. Okay, just very quickly about the normal sonographic anatomy of the kidneys. This is axial views here of the kidneys, both lateral to the spine. If you go a little bit superior to that, you will see the adrenal glands, slightly oblong-shaped, and obviously the bladder with the cord insertion and the two superior vesical arteries, which go into the umbilical arteries. And really what we're going to be talking about in terms of urinary tract enlargement today is megacystis, hydroureter and hydronephrosis, and hydronephrosis itself. And we'll talk a little bit about duplex systems, and if we have time, a little bit about multicystic dysplastic kidney, which kind of fits in urinary tract enlargement also. So we start with megacystis, and the commonest cause of megacystis is urethral obstruction, and the obstruction can be here in the urethra, or it can be due to cloacal persistence or urogenital abnormalities. A rare syndrome, megacystis microcolon syndrome, which we'll just briefly touch on, or you can have a large bladder because of polyuria, as you would in twin-twin transfusion syndrome. I'm not going to talk about TTTS. And urethral obstruction is really characterized by global expansion, if you like, of the entire urinary tree from the bladder all the way up to the kidneys. And the greatest expansion is at the level immediately above the obstruction. So in megacystis, you have a very large bladder, and as you get closer and closer to the kidneys, the expansion is less. And the expansion above the bladder is obviously due to a reflux, due to back pressure on the ureteric valves. Megacystis is defined as any bladder greater than 7 millimeters. So on the left here, you can see a fetus with a normal bladder, male fetus. And on the right, you can see megacystis, which is certainly more than 7 millimeters, and if you take a cross-section, you often can see the enlargement of the renal pelvises also. Once you've decided that it's over 7 millimeters, you then subdivide it into ones which are very large, more than 15 millimeters, and into ones that are a little bit large, 7 up to 15 millimeters. And it's important to make that division and distinction because the prognosis for those two cutoffs is different. This is a short video clip just to show you that megacystis can be really very large indeed. And that obviously is one of more than 15 millimeters. So this is a paper from Adolfo Liao from Kypros' group, where they divided 145 cases of megacystis into those that are less than 15 millimeters and those that are greater than 15 millimeters. And in the smaller ones, there's a high incidence of chromosomal abnormalities, mainly but not exclusively trisomy 13 and 18. And in the ones where the chromosomes are normal, the majority of these obstructions, 90% or more, will resolve spontaneously. On the other hand, those that are very large almost never resolve, and in this case, none of them resolved, and the incidence of chromosomal abnormalities was a little bit lower. So similar perhaps to exomphalos, where the very large exomphalosis are less associated with chromosomal abnormalities. Again here, a very large bladder is less associated with chromosomal abnormalities than a slightly smaller one. Nevertheless, the incidence of chromosomal abnormalities, even in the large ones, is very high. The obstructive uropathy is usually due to posterior urethral valves in male fetuses, so these are almost always male fetuses, or due to urethral agenesis or urethral stricture. or due to cloacal persistence, and we'll talk about that too. This is a typical appearance of a keyhole bladder. You can see there the large bladder with a keyhole appearance. And this is what a specimen looks like with posterior urethral valves. And these valves sit in the urethra and just block the exit of the urine. Apart from the first trimester, you can diagnose megacystis sometimes later on in pregnancy. These are late diagnoses of megacystis. Often difficult a little bit to diagnose later on in pregnancy, but if the bladder is above the upper limit of the insertion of the umbilical cord, that's likely to be significant. So these are later onset, probably milder forms, perhaps intermittent obstructions where the bladder and the posterior urethral valves act like a pressure cooker, so the bladder gets large, and then there's emptying of the bladder and increase of the bladder and emptying of the bladder, meaning that the amniotic fluid volume remains normal well into the second and third trimesters. So, once more, urethral obstruction there due to posterior urethral valves, urethral agenesis or strictures, and you get vesiculoureteric reflux, urine going up, you get hydroureter and hydronephrosis. And the consequences of urethral obstruction are really the sequelae of anhydramnios. Now, when does the anhydramnios occur in complete obstruction of the bladder? Will you see it at your first scan at 12 weeks? No, the fluid, amniotic fluid, will often be normal at 12, 13, 14 weeks because most of the amniotic fluid at that stage is still made by the placenta and exudate through the skin. And it's only after about 18 to 20 to 22 weeks that almost all the amniotic fluid is made by the bladder, and it's only at that stage that you will see the anhydramnios. But sequelae of anhydramnios, obviously pulmonary hyperplasia and limb deformities, urethral abnormalities, and because of the back pressure, dysplastic kidneys and renal failure in these infants. So we'll go back to our early diagnosis of megacystis, as we said, 7 to 15 and greater than 15 millimeters. So what do you do when you see such a case? Well, it would be sensible to offer prenatal diagnosis because there's a high incidence of chromosomal abnormalities. And then in the smaller ones, repeat the scan later on in pregnancy, perhaps in a couple of weeks, to assess whether spontaneous resolution has occurred. Obviously, you need to discuss termination. Now, even if spontaneous resolution has occurred, the sequelae, the cause for the obstructive uropathy, will still be there and it can get worse again. So this is a case where resolution occurred spontaneously. This is usually due to posterior urethral valves, an increase, we think, in intravesical pressure breaking through the posterior valves, and you need to repeat the scans to ensure that the amniotic fluid volume remains normal, or in other words, that the kidneys haven't been so badly affected that the fetus goes into renal failure. And you very often see thickening of the bladder wall. Can you see the bladder wall there? Very thickened. And almost always the kidneys will remain persistently enlarged for the rest of the pregnancy, often, or well into the third trimester, because the vesiculoureteric reflux, due to this very much enlarged bladder in the first trimester, will remain. So these kidneys will stay like that often 16, 18, 24 weeks, and slowly and gradually become smaller. But it is important to do repeat scans, as I say, for amniotic fluid volume and to check for repeat of the obstruction. What if the spontaneous resolution hasn't occurred? So you've done your karyotype, the karyotype is normal, the woman has come back, no spontaneous resolution. Again, discuss termination one more time. And then the question becomes, well, in these cases where spontaneous resolution has not occurred, should we intervene antenatally? And antenatal intervention, obviously, is quite an attractive thing to think about, because if you can remove this back pressure from the bladder, might you improve the symptoms? But it's important to remember that while you might treat the sequelae of anhydramnios, because by putting a shunt in the bladder, the fluid around the baby will normalize, you will not remove the original urethral abnormality. And if there has been damage to the kidneys, that won't be resolved either. And other long-term effects of megacystis include hyperplasia of the abdominal muscles here. This is part of the so-called prune belly syndrome. The syndrome, incidentally, isn't just hypoplastic abdominal muscles, but also includes cryptorchidism and other genitourinary malformations, as we said before, the primary cause of the obstruction in the first place. Another sequelae are the reflux. Here you can see a cystogram with urine tracking up these very large ureters right into the calyces there that you can see on both sides. And the bladder, that thickened bladder with a thickened bladder wall, means that there's bladder dysfunction with a hypertrophic, rigid, non-compliant bladder. And often these infants have mainly problems with bladder dysfunction if they make it through to postnatal life. So in this slide here, again, you have a baby with what is a massively enlarged bladder. Can you see that? Typical keyhole appearance there. And this is after placing of a pigtail shunt in there into the bladder. And that will allow the urine to drain off. So is antenatal intervention a good idea? The answer is we don't really know. This is a systematic review which appeared in 2003. I can tell you that there's another systematic review that will be published in the British Journal of OBGYN in the next month or so, which has enlarged the number of studies, but the findings are essentially unchanged. If you look at the 7 controlled series, which includes just under 200 fetuses, where they looked at bladder drainage versus no drainage, these are case control series, not randomized series. It appears that there's improved perinatal survival, just significant, but most of that survival is due to improvement in those with very poor prognosis. In other words, what you might be doing is transferring babies that have a very poor prognostic indicators in terms of long-term renal dysfunction and improving their survival, but obviously survival with major difficulties. So it may improve perinatal survival, but it may lead to more survival with very poor renal function. Just pause for a second and highlight to you the limitations of non-randomized studies of this nature. Because if you see a woman who, because of the enlarged bladder, decides to have a termination, she's going to do that anyway. You're not going to convince her not to have a termination to put a shunt in. So it's only in the cases that elect to continue that shunting then becomes an issue. And it is likely that you are more likely to want to shunt babies where you think the prognosis might ultimately be good. Am I making sense? If a case looks completely hopeless, you are perhaps less likely to insert a shunt. So there's all sorts of biases in looking at these kinds of data. In the UK, we have an institute called the National Institutes for Health and Clinical Excellence. The short version is NICE, although they are not always. And what they say is that fetal vesicoamniotic shunting for lower urinary tract obstruction should really be used only in a research context because there is a lack of evidence of safety and efficacy. Now, I got these slides from Professor Mark Kilby from Birmingham. They are running a trial called the Pluto trial, which is percutaneous shunting in lower urinary tract obstruction trial. This is a randomized controlled trial where single male fetuses with what appears to be isolated urinary tract obstruction are randomly allocated to shunting or expectant management. And the entry criterion is that the fetal medicine specialist should be uncertain whether to insert a shunt or not. In other words, if the fetal medicine specialist thinks that you must put a shunt in this case because otherwise it's terrible, then they can do that. And if they say, well, this is a completely hopeless case, I'm not going to shunt, then they do that. But if there's uncertainty, and the uncertainty should be quite large, given that there's no data, then you randomly allocate the patients to shunting or not. Apart from the randomized trial, they're also running a registry of these cases, which is very useful in terms of outlining the natural history. They're running a termination of pregnancy registry, and they're doing antenatal and postnatal follow-up. And postnatal follow-up is long-term follow-up, which is really important at year 1, 2, and 5 years. So we're not only interested in perinatal mortality, but also long-term outcome in terms of the renal function. The primary objective is really to determine whether shunting improves perinatal and neonatal mortality and renal function. The power calculation suggests that they need 150 patients, and later on this year there will be an analysis of the preliminary results. And this is the update from last Monday. There's 18 centers who are running this study, and they have so far randomized 24 patients. So a long, long way to go until reaching that 150. All of the Netherlands is now taking part in the study, I understand. So they're hoping that they're going to get a boost in their numbers. And as you can see, still the majority of patients going down the termination of pregnancy route. And of course, that's absolutely indicated if that's what the parents want. No one who elects for a termination is randomized in this study. So that's a little bit about Pluto. So is there a way then, antenatally, to find out whether the baby is going to have a good prognosis or not such a good prognosis? The data aren't very strong, but obviously if the condition is isolated, then that's a good prognostic factor. If there is hydronephrosis, then that's a good prognostic factor rather than having echogenic kidneys or cortical cysts, and I'll show you some pictures of that. And obviously, oligo or anhydramnios is a very poor prognostic indicator and almost always catastrophic. So these are the kidneys in obstructive uropathy. You will see them often being hyperechoic, and this is in the poor prognostic indicator category. So that's not good, but it's not as bad as that. That is worse than this. These are cortical cysts, and you can see these are small cystic areas which surround the kidneys, not these ones, those ones, there and there and there and there. Can you see those? Small cortical cysts. They're small cystic areas, and they're in the renal cortex. So they're separated from the pelvic calyceal system. And that is almost always associated with cystic dysplasia of the kidney and long-term renal failure. Urine or fetal blood biochemistry has been looked at, and these are some suggested cutoffs for good or poor prognosis. So assessment of the severity from the fetal urine. But the experience is rather limited, I would say, and there are disputes about some of these cutoffs. The group from Birmingham who are running the trial have also done a meta-analysis of urine biochemistry in prediction of poor prognosis, and they suggest that a sodium level which is above the 95th centile and a calcium level which is above the 95th centile have the highest prognostic indication for poor renal failure, for poor renal function, but the likelihood ratios are not terribly high, so not an enormously useful sign. So that's that about urethral obstruction. Spot diagnosis? Anyone? So you've got a large bladder here. It's difficult because actually the diagnostic feature isn't on this slide. But the one thing to notice here is an increase or normal or increased amniotic fluid. And this is something that you can see in megacystic microcolon syndrome. In order to diagnose megacystic microcolon syndrome, really what you need to see is you need to see the dilated intestinal loops which are upstream from the hypoplastic segment of the bowel. Okay? And that's very difficult to see. But the presence of normal or increased amniotic fluid is often a giveaway. The other giveaway is that, unlike obstructive uropathy, these are more commonly female fetuses than male. You get shortening and dilatation of the proximal small bowel, absent and ineffective peristalsis, and this is usually a lethal condition. I'm not going to talk any more about megacystis microcolon syndrome because it's rare, and if you've got an interest, it's better to read it up. Very quickly on cloacal persistence. Remember that in early embryonic development, the digestive tract, the urinary tract, and the genital tract have a common outlet, which is called the cloaca, like in birds. And then separation occurs of those by that downgrowing there, and you get a separation of the urinary tracts and the digestive tracts. And if that doesn't happen, or if it's incomplete, that's when you get what we call a persistent cloaca or cloacal abnormality. Often, because of this, there's an obstruction to urinary flow, and that causes obstruction upstream due to a urogenital abnormality. And the clue really is a complex sonographic appearance. So usually in urethral outflow, you get a regularly rounded bladder with anechoic urine inside, that keyhole appearance that we showed earlier. Whereas in cloacal persistence, you often get other features. In this case, you have this funny anomalous plication here. And in this is the bladder here, and you have echogenicity within the bladder. And that echogenic material is almost certainly meconium due to the common opening of bowel and urinary tract. We'll come back to that. Sorry. Okay. So we'll come to hydronephrosis and hydroureter and move away from megacystis, move up the urinary tract a little bit. And hydronephrosis affects about 1 to 3% of fetuses. And there are really three causes. The first is functional, so we don't really know what causes it. Possibly hormonal, due to reduced peristalsis of the urinary tract in pushing the urine down to the bladder. The second is reflux. From where the ureter is inserted in the bladder, you get reflux of urine up. And the third is obstruction. And you can have obstruction at the pelvic-ureteric junction, at the vesico-ureteric junction, or the bladder outlet, and we've talked about that already. So obstruction here, bladder outlet, pelvic-ureteric junction, so this is the renal pelvis and the ureter, or vesico-ureteric junction there. And reflux is different. Reflux is where this little valve, it's not really a valve, it's just how the ureter enters the bladder at an angle. But if that's leaky, you get urine flowing back up as the bladder contracts down. This is just a short schematic of the kidney, because we're going to be seeing some pictures of the kidney. So the outer part of the kidney called the cortex, the inner part of the kidney called the medulla, and the medulla is made up of about 6 to 18 structures, these conical structures here, which are called the pyramids. And each one of those pyramids drains into a minor calyx. Can you see that's a minor calyx there? And the minor calyces join together to a major calyx. And there's usually 3 to 4 major calyces. And those major calyces drain into the pelvis, into the renal pelvis. Just a tiny bit of embryology. The kidney, all of the cortex and the medulla, come from the metanephric mass, and the ureter, which arises from the mesonephric duct, and the ureteric bud grows into the kidney. So you've got the kidney developing from one side, and the collecting ducts arising from a different side, and they meet up. Okay? And that's important when we talk about multicystic dysplastic kidney. We'll re-mention that then. So here you can see the calyces. And normally in the kidney, you should only really see the renal pelvis being dilated. You shouldn't be able to see anything more than that. And if you have calyceal dilatation here, you can see the major calyces being dilated around this kidney. That obviously is a dilated urinary tract. Or, of course, you can have just an increase in the diameter of the pelvis itself. Now, what is the normal AP diameter of the pelvis? Well, there's a little bit of debate about this because there is variability, But the largest series and the biggest paper is from Shanti Sairam, shows that anything above 4 millimeters at 18 to 20 weeks is significant. And in that paper, they defined mild as 4 to 7 millimeters, and moderate to severe anything more than 7 millimeters, with a third trimester scan being significant if it's more than 10. And when you do a scan and you see hydronephrosis, really the things to think about is characterize it first of all, whether it's mild, moderate, or severe. Make a comment whether there's calyceal involvement. Are the calyces dilated, like we saw in that previous picture? Look at the ureters. Normally, you should not be able to see the ureters. They're not visible. And if you do see the ureters, then usually that means that the ureters are dilated. And finally, very importantly, make a comment on the amniotic fluid volume. You can also, if there is calyceal dilatation, make more detailed comments about the kidney itself, whether there is echogenicity in the kidney or not. So here you have a normal renal pelvises, mild dilatation there, and mild dilatation with calyceal involvement. Of course, when you see bilateral mild hydronephrosis, the question comes regarding the risk for Down syndrome. It's been traditionally considered a marker for Down syndrome, but it's very important here to think whether it's an isolated abnormality or not. Because an isolated abnormality, isolated mild hydronephrosis, has a likelihood ratio for Down syndrome of exactly 1. That means you multiply the background risk by 1. That means if the background risk was 1 in 500, it is now 1 in 500. It doesn't change in isolated hydronephrosis. And the reason that happens is that although hydronephrosis is slightly more common in Down syndrome pregnancies than in normal pregnancies, the absence of a short femur, of an echogenic bowel, the absence of an echogenic focus, etc., brings the risk back down again, which is why you end up with a net plus-minus risk of 1. So when you see mild hydronephrosis, you do that anyway. You should be looking for other markers of chromosomal abnormalities. And if there are many other markers, then that may be significant. If it is an isolated marker, then there is no increase in risk, provided this is a previously screened population. And finally, if there's been no previous screening at all, and this is the very first scan this person has, then really you should probably increase the risk by a factor of about 1.5. Do you understand why, if someone has had no previous screening, the risk goes up while it doesn't change if they have had previous screening? It's because the incidence, the change in risk will depend on the incidence of the condition in your population. If you've got 10,000 fetuses that have previously undergone first trimester combined screening, and most of the trisomy 21 fetuses have been removed from that population, the risk remaining in that population becomes very small. Whereas if they've had no previous screening, all those fetuses are still in there. Does that make sense? So there's a difference in the incidence of the disease in the population background. So this is Shanti's study, and she looked at routine population of just under 12,000 pregnancies and looked at the AP diameter of the renal pelvis. As I said, anything between 4 and 7 was considered mild, more than 7 was moderate, and a repeat scan was done at 30 weeks. And of the mild cases, 90% resolved. So these are the functional ones. Remember how we said the causes are functional, obstruction, and reflux? So 90% of mild hydronephrosis resolved, so these are likely to be the functional cases. And of the remainder, the remaining 10% was roughly split equally between obstruction and reflux. In the moderate group, however, the risk for postnatal surgery was 1 in 3, or a 30% risk. Again, slightly more commonly reflux than obstruction in that particular subgroup. And the most predictive feature of whether a fetus needed postnatal surgery was a third trimester scan, and probably it's true to say that the closer the scan is to delivery, the more likely it is to predict the outcome. If there is progression of the hydronephrosis, if there's significant calyceal involvement, if there are multicystic changes in the kidneys, those cystic dysplastic kidneys that we saw earlier, or if the amniotic fluid volume is affected, then those are the predictive features for needing postnatal surgery. So, just in summary, hydronephrosis, we need to exclude an associated abnormality and repeat a third trimester scan. If the pelvis is less than 10 millimeters, which means it's normal, and the calyces are not visible, then in our unit we do no further follow-up. Although in many other places they will still have a postnatal scan. If it's greater than 10 millimeters, or if the calyces are dilated, postnatal imaging is needed. And the postnatal imaging is an ultrasound and usually avoiding cystourethrogram. If the fetus is male, then that needs to happen very soon after birth to ensure that there's no bladder outflow obstruction. And antibiotic prophylaxis. And the reason we do antibiotic prophylaxis is because antenatally it's not possible to distinguish reflux from obstruction. And what happens in reflux, and this is a cystourethrogram here, you can see the bladder filled. This is unilateral reflux. You can grade reflux. This is how it's graded postnatally, whether the dye just goes into the undilated ureter, or if there's dilated ureter into the pelvis or into the calyces, the grading increases. This is a grade 5. And if you have reflux, urine goes up into the kidney, and babies get frequent urinary tract infections. And what you don't want is infected urine to go from the bladder into the kidney and cause infection of the renal structures. This is why you give prophylactic antibiotics. Just one other thing to say, of course, not all of them will be picked up. This is a nice study from Anderson from quite a few years ago now, which looked at obstructed kidneys and unobstructed ones. And while the differences become very obvious in the third trimester, actually at the 20-week scan, quite often the renal pelvises are normal, which is why we've all experienced a woman who's coming for a routine growth scan in the third trimester. Everything looked normal at 20 weeks, and you look at the kidneys, and the renal pelvises are very enlarged. So this is not it's an unusual but well-documented phenomenon. Okay, so far? Duplex kidney. So there's a particular variety of hydronephrosis which is due to a duplex kidney. And in a duplex kidney, you've got two pelvic systems within the same kidney. So you've got one kidney, and remember how we said that the two things grow from separate sources. Here you've got duplication. And you can have various forms of this. You can have two pelvic collecting systems that drain into one ureter. But the most common one is this particular variety, where you have presence of two pelvises and two completely duplicated ureters. And interestingly, as you can see, they cross over, and this is usually what happens. The lower pelvis drains into the normal ureter, and the upper pelvis drains into the lower one. And you know this happens because if you remember from your embryology, the kidney develops, of course, down here in the pelvis and moves upwards with gestation, which is why these two ducts that are originally like that, as the kidney moves up, cross over. So that's an easy way to remember why that happens. This ureter here inserts at a normal angle, and therefore usually this pelvic system is not dilated. But this ureter here inserts into the bladder trigone and not in a normal position, and that means that the valve or the non-valve that we discussed that keeps this closed doesn't function properly, and you get reflux. The lower pole may also expand, and we'll come to that in a second. It's not a terribly common finding, but you will see it in a busy unit. And as I said, it's the upper moiety that's dilated. Now, the lower moiety can get obstructed, and a common cause of why that happens is a ureterocele. So this is that abnormal ureter that inserts lower. Remember, it inserts lower. It's coming from the upper moiety of the kidney, and it creates that mucosal, that prolapse of the mucosa within the bladder wall. And if this becomes very large, that little uterocele, then it can obstruct the other ureter from the good part of the kidney. And ureterocele is something that you see almost exclusively in duplex kidney, although it can happen with other malformations as well, such as multicystic dysplastic kidney. A summary slide on hydronephrosis. We pick up about 40% of congenital uropathies in utero. Hydronephrosis that is greater than 10 millimeters in the third trimester. Dilatation of the ureter is always pathological, or dilatation of the calyces is always pathological and requires postnatal investigation. Even with severe hydronephrosis, if the amniotic fluid volume is normal, the prognosis is pretty good. So you know how we talked about the prognostic features and how the kidney looks like and all the biochemistry? Probably the best prognostic feature is the amniotic fluid volume. And if the volume is normal, the urine is being produced by the kidneys and the prognosis is good. And usually, even with severe hydronephrosis, we allow full-term delivery. Bladder outlet abnormalities are a little bit more difficult, and we've talked about the pros and cons of shunting and the uncertainties that exist. And there is nothing more characteristics that will tell you that there's uncertainty about a procedure than someone running a randomized trial to establish whether it's better to shunt or not to shunt. So since we have another 5 minutes, we'll just quickly go through multicystic dysplastic kidney. And you might find it surprising that it's a urinary tract enlargement, but it is kind of a urinary tract enlargement. And it's not entirely certain why multicystic dysplastic kidney occurs, but you remember that we said that the mesonephric duct and the ureteric bud grows into, the calyces grow into the metanephric mass, which makes the kidney up. And if there's a disordered development of that, the two don't meet up. And that's one theory of how MCDK occurs. It doesn't explain why in some cases there's absence of the renal artery. So there may be other reasons. Or it may be, so it's a kind of an early obstruction, really. And you see these very many cysts, and they're typically of very different sizes. So you get a little one and you get a big one, and it just looks like a mess, really. And that's what multicystic dysplastic kidney looks like. The most important prognostic feature in multicystic dysplastic kidney is what the opposite kidney looks like, what the amniotic fluid volume looks like, and whether there are any associated abnormalities. If it is bilateral, these are non-functioning kidneys. Multicystic dysplastic kidney doesn't produce any urine. Okay? So if it's bilateral, it's lethal, and anhydramnios will develop and all the rest of it. If it's unilateral, fortunately, because you only need one kidney, and there are no other abnormalities, the prognosis is good. One of the challenges sometimes is to tell apart multicystic dysplastic kidney, where you have these many cysts, from severe hydronephrosis with calyceal involvement. And it can be a little bit difficult. So this is within the differential diagnosis. And the way to do it is, when you've taken the cross-section of the kidney there, is really, you can sort of get the impression that these cysts are all separate. But remember that if you move your probe just in the coronal plane up and down, if these join up into that means they're all joined up, and that's hydronephrosis with calyceal involvement. So they're all continuous there. Can you see that? And if you move just slightly out, then that's the same picture as that, which is separate, different from this one, where really you get cysts, and you can look around the cyst, and it doesn't join up with any other neighboring cysts. So this is a case here of multicystic dysplastic kidneys. And another. And as we said, a unilateral multicystic dysplastic kidney has a good prognosis, but it is important to look at other abnormalities. And there are associations with multicystic dysplastic kidney. So here we've got a hemivertebra. Can you see that? That one goes with that, and that with that, that with that, and that with that. And then that one doesn't go with anyone. And then those like that. So a hemivertebra. Absent stomach there. Any ideas? Very good. So bacterial association, or of course there are other abnormalities that can be present, trisomy 18, genetic syndromes, and cardiac defects on their own. Someone is going to ask me whether we should do an amniocentesis for every case of multicystic dysplastic kidney. I think that if the risk is low and if there are no other features of trisomy 18, it is unlikely to be the sole marker for trisomy 18. And I think, Boris, that is all I have to say about urinary tract enlargement. Thank you very much.